All right, it's great to see everyone this morning, and it's my pleasure to introduce a colleague and friend, Dr. Osagie Ebekozien. He's the Chief Medical Officer at the T1D Exchange, and the T1D Exchange is the largest diabetes learning health network, over 80 US endocrinology clinics, learning network in diabetes. He's also an adjunct professor of population health at University of Mississippi Medical Center, where he teaches graduate level population health and quality improvement. And Dr. Ebekozien's research is focused on diabetes health equity, quality improvement, and population health science to improve real-world outcomes. He's received numerous awards for his work, including the 2021 ISPAD Innovation Prize and the 2022 Leonard Award for Diabetes Research. So Osagie, real pleasure to have you here. He also will speak tomorrow at 5 p.m. at Endocrine Grand Rounds. So if you like this one, you can let me know and we'll get you connected for that one tomorrow. So Osagie, welcome.
Thank you. I appreciate it. I appreciate you. I think this is on, so I like to walk around as well, so you guys will indulge me. Thank you all for being here. True honor and pleasure to be here. I told some of my friends, good to see you, prayer, that I'm coming to Stanford. They're like, wow, you're coming to Stanford. So I am in Stanford now. I'm really excited to be able to share with you all as well. So let me make this work. And also appreciate you, David, Dr. Maz. It's been a great friend and a mentor as well, and I appreciate all of your support over the years. These are my disclosures. All right, so I'll talk about a few things. I'll do this for the next 40 minutes or so. I will talk about what learning health systems are, and why they're important, and why I'm excited about that. I will describe successful example of learning health systems. My aim is really to ensure that we all can live with one or two key things from today's talk. Talk about real-world data and learning health networks, learning health systems, practical approaches that we use to address inequities. But I think all of that, these are a lot of big words, and I had to make sure we have big words for the CME folks to say, yes, this is important. We need to check this box. But I think if you are going to take away one thing from all of the conversations we have today, I'm hoping that one is that you find a learning health network or a learning health system involving your area of care, your area of specialty. So you're in ID, you're in ER, you're in cardiology, whatever your specialty is, or primary care, there's a learning health network or learning health system doing the work collectively in that area, and I'll describe what it is. So my hope is that you are excited enough about, I want to be a part of a learning health system, or locally here at Stanford, I want to be a part of a learning health network, even outside of that. Now, if you do that search and you find out, well, there's really nothing in my field or nothing in my space, my hope is to challenge you to think about how do you bring together other collaborators outside of the Stanford system to come together to work on something. So can you hopefully be inspired to start up something if there's none already existing in your space? So those are the two key things I'm hoping that we would leave with that shared understanding. I would describe different examples, but I really spent about 2/3 of our time talking about the T1D Exchange Collaborative. My intent with that is to use that as an example of what that could look like in your field, in your specialty, in your space, and hopefully that we all leave with one or two key things there as well. But before I do that, I want you guys to meet two people, Avi and Amaris. So that's Avi. Avi, it was a shock, yeah. And this was at a birthday party earlier this year. And that's Amaris. Avi is 7, Amaris is 9. Avi's birthday is December 19th, so he'll be turning 8 later this year. And Amaris, she'll be 10 next month. They also happen to be my kids. They happen to be people that keep me challenged, keep me going. And when I do talks like this across the country, I remember earlier this year, my daughter, Amaris, she asked me, Daddy, do people get anything from all of these talks you do? I don't know how to take that, Amaris. My ego right there. And I'm like, I think they do. I hope they do. So I hope you get something out of the talk today, because I have to go back to report to Amaris, so whether or not you guys learned something. But Avi and Amaris, like my kids, like some of you here that might have kids, or have others that you care for, a parent figure or an uncle or an auntie. We all care for kids And that's why where we are today. That's why we're interested in this work. That's why we're collectively working on different aspects of the work we do. It's for these kids, it's for children. And so for me, I think about all of the conversations we're going to have today, and I think about Avi and Ames. And the question I ask myself is, how can we guarantee that if Avi and Ames have to be here in California tomorrow, next week, next month, that whatever care they get here will be the same care they get in Boston, will be the same care they get in New York, will be the same care they get in Miami. And that's a big question that we all need to ponder on and we all need to think about. Because the whole concept of learning health system is, can we collectively come together to ensure that every single life, every single child in this case, can receive the same type of care, irrespective of where they are. And and we're far from that now. But that's the reality we're working towards. That's the vision we're working towards. It's trying to get to that place where we can really create better systems, better environments, a shared learning space, a true learning community that gives every child, irrespective of where they are, an opportunity to have improved outcomes. So that's where the whole concept of learning health network comes in, and learning health systems. And those are two different phrases, and I'll describe them. But before I do that, you think about all of the things happening here. So I recognize where we are now at Stanford. This is a great institution of learning, of research. So many amazing things happen here. But all of that science that's being generated here, how much of that leads to evidence? And by evidence, how much of that becomes like, this is the new guidelines, this is the new way we're going to do this across the country, across the state, across the city? How much of that actually leads to care outcomes? How much of that leads to, this is how I'm doing it in my clinic today, and the patient I'm going to see next week, the patient I'm going to see next month, they are all receiving care based on evidence, based on the science. So now there are a lot of poorly managed insights from our science, and then evidence not being used properly or sort of poorly captured experience. And how much of that actually leads to the patient experience? How much of that leads to what Avi and Amaris and all of the other kids that we care for would receive? So this is the problem we're trying to solve for. What we're trying to solve for is, how do we ensure that we can close some of these gaps and waste that really prevents insights and science that's generated to lead to patient experience, to lead to the outcome we want to see? And I hope that collectively we can all agree that we do have a lot of missed opportunities, but more importantly, there's something we all can do about it, irrespective of where you see it, irrespective of your specialty, your field. We all can collectively work to make this a better experience, using all of the evidence, using all of the science being generated, the insights, the research, amazing research being done. How do we bring it all the way to where patients are actually benefiting from that? And that's the concept of learning health networks has sort of grown over the years. There are numerous publications inside of this, and even there's actually a journal now focused on that, Learning Health System Journal. So if you want to read more about that, there are tons of resources in this field for learning health systems. But what exactly are they? And the highlights are mine. So in the learning health system, internal data, it's sort of the first key there, and experience are systematically integrated with external evidence. And I'll pause on the internal data and thinking about internal data in a very broad lens. So all the data being generated routinely from your care, generated routinely from interactions of the nurses with the patients, the medical assistants, the MDs, DOs, everyone working collectively to care for the patient. You're generating some form of data. Your experiences as providers, as care team members, the experience of the patient, that's also generating some form of data. So how are we collecting all of that in a systematic way? That's the first big question. Because whatever insights, for that insight to be properly managed, the data needs to be collected in a very confirmed, systematic way that we can replicate, even for routine data. Then the second piece of that highlighted there in bold is external evidence. How about what's happening outside of your routine practice? What's happening outside of the Stanford system? What's happening down the street? What's happening in other states? Are we able to collect that information in a systematic way alongside our internal data, our internal experience, and use all of that and put that into practice today? So how do we get that from just, Priya is caring for our patients and she's doing this and Ananta is doing that? How do we get the insight and the experience and the data from what Ananta is learning every day and what Priya is learning every day and what Grace is learning every day? How do we bring all of that and connect that with what Joyce, Grace Lee's sister, is learning on the other side in Michigan? How do we bring all of that piece together to think about putting that into practice here at Stanford? And Joyce also doing that, putting that into practice at Michigan. And that's a big problem. That's a big puzzle. And that's really what learning health systems are aim for, to really think about that as well. So you think, so sort of what I just summarized there, we're collecting all that evidence, the data leading to evidence, and that feeding into practice. So the 6 things need to be in place for us to have a truly effective learning health systems, and I would describe each of these 6 in different capacities. The first is real-time access to knowledge, and we've talked about that, and we'll talk about that some more. I'll show you an example of how we're doing it at T1D Exchange Collaborative to sort of create this space where everyone has access to real-time information. Everyone has access to real-time data, because we start there. Then the second piece is culture of trust and transparency. Are we vulnerable enough to share exactly what we're learning and vulnerable enough to share where we're doing well, where we're not doing well, where we have room for improvement? Are we vulnerable enough to share this is some of the pain points or the problems we're still dealing with? And share that even with competitors, and share that with folks that on the business side might be like, no, we don't have this kind of conversation. Well, can we think about outcomes from the perspective of the patient, outcomes from the perspective of the kids, for Avi, for Marys, for all of the kids that you all care about? Can we think about the culture of trust and transparency for their purpose, for their lives as well? Engaged and empowered patients. How engaged and empowered are the families we care for, the kids we care for? Are they involved in critical decisions on what happens to their own care? What happens in the clinic with them? What happens outside of the clinic? Are we having those conversations in a very systematic way? Now, I know those pieces to some degree it's happening all the time, but the challenge is, are we thinking about it in a very strategic way on, this is how I'm capturing and empowering patients to be engaged, to share feedback in the quality program, to share feedback in the 4T program, in any of the other programs we're involved with. And I'll give you some examples of how we're doing that to the T1D Exchange Collaborative. How about leadership? Leadership with sustained investments, commitment to learning and sharing, optimizing access to quality data, and using that quality data to drive ongoing improvement. So those are 6 different aspects for us to have a true system that emphasizes not just the science, because there's a lot of science happening here, and just driving through this morning, seeing all of the big buildings and all of the different institutes, I'm like, wow, yes. So all of that science happening, how much of that is leading to evidence? How much of that is changing our standards of care? And I know many of it is, but are there still missed opportunities there? And all of that evidence, how much of that is leading to care outcomes and care improvement? Not just at Stanford, but care outcomes and care improvement even outside of Stanford. Because that's the whole gamut of what we're trying to work on and solve for together. So there are many examples of this, and I will describe that, but learning health systems is all of those 6 components. Now, learning health networks are where you have multiple learning health systems coming together with a sole purpose on, we want to work and improve this issue or that issue. So learning health networks are just a collection of multiple learning health systems. But learning health systems is what needs to include all of those 6 different components of data, optimizing the processes, looking at engaged patients and what have you. So you have patients involved in learning health systems, clinicians, the researchers, all of this group collectively, different learning health systems combined together, working across different learning health networks. And I'll show you an example of what that looks like. So more than 140 different hospitals are working on patient safety. So you have 140 plus different hospitals, and I believe Stanford is one of the centers as well, and created a learning health network. Now you have multiple learning health systems, created a learning health network to focus on patient safety. My goal here is just to give you examples, and I will really do a deep dive on the type 1 diabetes example to sort of go through all the details and the weeds of that, right? But okay, well, what if, and that's sort of been successful and really helpful, but how about cystic fibrosis? Again, emphasis here, another example to hopefully leave you inspired with this, to think about your field, your space, what you're working on, your interest area, and is there a learning health network already working on a certain issue that you can be a part of and plug in? Or if there's not, can you think about sort of coming together with a group of people to get involved in one as well? And how about juvenile idiopathic arthritis, the PR Coin, another learning health network working on looking at improving outcomes for kids impacted with this. How about even in very rare conditions like single ventricular congenital heart disease, and you have a lot of other rare conditions or rare diseases that learning health networks are formed all across the country. The beauty of this is when we pull together our resources, not in a research infrastructure now, there's already a lot happening in the research space, multi-site, multi-center research. That's not what I'm talking about. That's good because we need that to establish the science, to establish the research that will lead to the evidence. But what I'm aiming for, what I'm talking about is bringing together a network of centers and clinics to take that science, take that research, and make sure that that becomes everyday practice. So that's where Learning Health Network comes in, and that's where it differs from a multi-site clinical trial or multi-site research group. It's more on a practice-based, implementation-based focus versus with generating the evidence or generating just the science in that space as well. And then another example, I'll wrap up with this example here, looking at the IROC work to improve renal outcomes as well. All right, so with all of that being said, I did promise that we'll spend bulk of our time here, which we will for the next 20 or so minutes, on the T1D Exchange Collaborative and the work of T1D Exchange as a learning health network with multiple learning health systems really aimed at trying to drive and improve outcomes for children with type 1 diabetes. So this is the problem. This is where we started from. In 2010, 2012, with a lot of work and many of the folks in this room as well to leading this effort, created a multi-center research infrastructure. And I see Bruce and I see a lot of the leaders too that were instrumental to putting this together. And then you fast forward to 2016, 2018, and this whole multi-center learning research network was doing a lot of great things. Was generating evidence in the space, really generating evidence to help improve our understanding on type 1 diabetes management, insight for type 1 diabetes. Where do we go from here? A lot of the new technology in the space really came from some of the work being done by the T1D Exchange sort of multi-site clinic registry, which was sort of a research network, a research registry. But when we looked at data 2010, 2012, and compared that to 2016, 2018, unfortunately, all of those efforts was not necessarily translating to improved outcomes. And to orient you to this, you're looking at mean A1C on the vertical axis and then the age on the horizontal axis. In the upper colored, I think that's blue, 2016, 2018, and compare that to the orange, 2010, 2012. And for mean A1Cs, you want that lower sort of being better. And there are multiple reasons we advertise for why this was sort of the outcome that was seen then. But I think this was a big shock to the system. And this was sort of a wake-up call to, why this outcome, why what outcomes getting worse. Now, you might sort of puzzle, well, I didn't, that perhaps there are multiple things that could drive that, and that's true. But in a separate study with Ryan and David Mass and other group looked at how about when we compare how we're doing to what's happening in England and Wales, and compare that to also what's happening in Germany and the German registry, the DPV registry, and other countries as well. And two things to sort of highlight there. First is you look at use of insulin pumps, and like, well, we were doing pretty good even as of 2018 with use of insulin pumps there, much higher than what was happening in DPV and NPDA. DPV beating German registry, NPDA, England and Wales. CGM use was also about, we're sort of between DPV and NPDA. But now when we looked at outcomes there, in A1C outcomes, where the NPDA and DPV were doing much better than what was happening there with, in the US using the T1D Exchange data, the clinic registry data. So again, multiple reasons we can explain this, but my big point here is what we found is that just having a multi-center research collaboration alone in of itself doesn't always just translate to improve outcomes. Without a very systematic process of taking all that science, all that insights, and bringing it into everyday practice. So we need the science, we need the evidence, we need that to push the outcomes, but we need a systematic process to take all that science, all that research, and to ensure that that actually gets spread across not just one center, not just two centers, but across multiple centers to walk through the kinks of what does this look like in practice today? What does this look like in practice tomorrow? What do we need to do differently? What do we need to change in our workflows? What do we need to make adaptation for? And that's really where the power of a learning health network and learning health system comes in. It's to think about, we see what we see now, how do we make that change collectively as a group, and having trust and transparency, which is one of those components of a learning health network of this is where we are and we want to do better. So how do we do better? What do we do together collectively to push us there? So with that as the background, the T1D Exchange Quality Improvement Network started in 2016 and really sort of expanded in 2018, 2019. And our goal was very simple, was to take all of the brilliant research that the T1D Exchange Clinic Registry had done before, and some additional new evidence, new research coming in the face. How do we take all of that and use that to drive improvement in outcomes in the clinic routinely? Not as part of a research network now, but as part of an improvement network or as part of a learning health network. So we've since expanded, and now we're at over 60 centers caring for more than 200,000 lives. And you sort of see the maps here highlights where all of our centers are located. And just to show you some of the logos of the different centers that are part of our network as well, in both pediatrics and adult centers. But what's more important is our approach on looking at real-time access to data. It's sort of taking a different lens at this. We're like, well, look, we want to have access to data today. And one way to do that is, can we have access to the electronic medical records data routinely, that's been seen routinely? So if we have a patient that pre-sees today, tomorrow, can we have access to whatever data insight from that patient next week and next month? So to do that, we went through a process called data mapping, where we'll work with the IT team in the different hospitals to sort of extract and map this data and set up a recurring data push. So with some centers, it's weekly, with some centers, it's every other week, some centers, it's monthly. But what that gives us is really reduce some of the friction in moving in the data and make that data available to you, make that data available to everyone that is interested in learning what's happening now, what's happening today. So with our process, we've been able to actually build a database, and now it's more than 114,000 lives, routine data updated every week, every 2 weeks. What this gives us insight to is, if we want to answer, Dr. Buckingham wants to answer a question, for example, on where are we with use of AID across the country, that question can be answered quickly in real time today, just by looking at, by logging into the portal and seeing where things are. I want to answer a question of, how about depression screening? Dr. Prahalad is like, how about depression screening? Where are we with that? How do we push that forward? What's happening, not just in my center, but what's happening across other centers? Now we push that and we're able to log in and see that piece as well. The other component to this, and why we sort of get very excited about this, is we've built this network that 1 out of 4 kids with type 1 diabetes, we have access to their data and can get some insight into what's happening. So this is beyond just 2,000, 3,000, 1,000 patients for a condition like type 1 diabetes, having access to look at outcomes for 1 out of 4 child, and in our case, 1 out of 7 adults with type 1 diabetes in the US. So that gives us real-time insights. And that also helps with a lot of the other things we're able to do to sort of push that conversation to the next level as well. So that's sort of the first component there of real-time access to data, working on the data to bring it together, shared definitions or shared terminologies, mapping that data, working the IT team, the legal, all of the folks there to say, well, can we bring the 2,000 patients you care for at Stanford with the 6,000 patient at Barbara Davis, or the 1,000 patient at Michigan, pull all of that together and see where we are so that we all have access to that and we are able to use that to drive improvement in outcomes there. But we use that data to do a lot more. And Dr. Prahalad did this paper last year where we looked at how do we truly, living up to the spirit of a learning health network and living up to the spirit of shared learning, how do we benchmark and compare what's happening across different centers? And you see there that centers are sort of blinded with ABCD, because our goal is not to shame centers. Our goal is to sort of show this is where we are in real time. And more importantly, what can center A learn from center Q or learn from center D? How do we bring that conversation to talk to center A on like, oh, look, this is where we are with CGMEs in 2021, 2022, 2023. And this is the size of your center. This is another center of equal size or what have you. This is how they're doing in the same states or in different states. What's different? What can we learn from your process in center D that center A can bring into practice today? So we use insights like this to push the conversation forward, because we want to make sure that if Avi and Maris are being seen at center A, they get a chance to be able to get the same outcomes as they're seen at center D or they're seen at center M. And for folks that sort of came in late, Avi and Maris and Miami referenced them. Those are my kids, as in the 7 and 9-year-old, which sort of using that as we think about as they move through that spectrum of a learning health system or learning health network, where are they in this space, and how do you use that to push that piece forward? But more importantly, we can also use those same insights to drive ongoing improvement as well. And this is another paper where Priya looked at, with Dr. Myers David, working on looking at outcomes there and driving that and pushing that piece forward to improve technology use. But the data insight helps with more than that, with benchmarking, but also sort of, to give you a snapshot of what that looks like here, to drill down on like individual sites, what's happening there, looking at demographics, looking at key information and comparing that with others as well to really move that piece forward. But then can we take this data and use this data to help us think about mimicking or modeling other kinds of studies? So in this work we did with that we published at JDST, we looked at, well, what happens when people get off technology? When they get off CGM, what happens to outcomes? When they get back on, what happens to outcomes? And then sort of being a little creative on using the data and trying to longitudinal data now in this case to really try to understand key highlights, key variables. But there's so much other power and so much other insights that can be generated from a broader pool when we're all coming together collectively to sort of share that resource, share data as one tool to really help us answer key questions to move the conversation forward to get to where we need to go. So that's sort of that first piece on data and what we've done there. And something else you all can think about, it's how do we really ensure that routine data from the electronic medical records used every day or generated every day, it's that data serving another purpose to improve outcomes for patients that are going to be seen tomorrow. So that's the question. It's the data you're generating today really going to help create a difference tomorrow routinely as part of our ongoing work as well. So with people living with type 1 diabetes, and my wife has type 1 diabetes, which is part of how I got involved in the field, and part of why I'm also sort of driven to continue to do this work as well. Are we collecting the voices and the impacts of those living with that specific disease or that specific condition? And not just in advisory groups, which we do have, but they can in other parts of care teams. Are they involved in giving us feedback on workflows? You want to make a change in the clinic tomorrow on your rooming process, or you want to make a change in the clinic tomorrow on the lab ordering process. Have we engaged patients on that to gather their experience, and not just satisfaction, but even sort of the more practical aspect of that, of like, how will this make a difference in your schedule? How will this make a difference in you being able to care for your patient, your child, or you being able to support your teenager, or any of those other concerns as well? And so, for example, even our patients, came together and put together a resource for other patients. So this is a sick day management. And this is all done by engaged patients from different clinics coming together to say, look, we see a need here, we see an opportunity here, let's do this. And this is one of the many resources that our group has done. But patients also have a very, very important role in even helping push the conversation beyond just being engaged in the clinic. So we do a lot of work now with all these organizations listed here, and I'll highlight two of them. So just 2 weeks ago, actually 3 weeks ago, I was at the Center for Healthcare Strategies annual convening in Austin. And what that is, it's a group of Medicaid policy stakeholders, but more importantly, there are patients that were involved in all the conversation at Austin. And what we're really trying to drive out there is, how do we get more voices of people impacted by Medicaid policies? In this case, CGM coverage, AID coverage, or diabetes technology coverage. How do we get their voices so that we collectively can push changes in Medicaid coverage? So we're working with 7 states now. And that's one of that work there. The ACHP, the Alliance for Community Health Plans, that's for sort of community health plans, similar network. And they're working across 20 states. Similar concept of, we have this insight, we have these technologies, we have all this piece. We still have restrictions and barriers with insurance, with this, with that. How do we push that work forward, and how do we sort of drive that? And that was in Minneapolis earlier this month. So again, many things happening here, but having voices of patients working with us, working with the data to really drive and push that advocacy really gets us to where we need to go on pushing and moving that forward. Then sharing and learning, and the sharing and learning, I've talked a lot about, you learning from Michigan, or Michigan learning from us, and all of that piece. But how about outside of the country? What's happening in Germany? What's happening in Austria? What's happening in Australia? What's happening? What can we learn from how care is being done there for, palliative care? How care is being done there for rheumatoid arthritis, for idiopathic arthritis, for any of the other conditions we're sort of involved with. And Dr. Myers later chairs our international collaboration efforts. So we're doing all this work to sort of learn from Germany, from Austria. What are you doing differently? How does it compare to what we're doing here in the US? What can we learn from your processes, your system, for us to bring that to what we're doing here and spread that across to the different centers as well? And just yesterday, last week, the Lancet paper looking at outcomes for more than 100,000 children with type 1 diabetes over a 10-year period was published. And what we showed there is, yes, we're improving outcomes, but there's a lot we can learn from 8 other countries sort of doing similar work as well. So, and then even sort of going further east to thinking about what can we learn from our colleagues at China, and having that collaboration with them to learn and share. But it's also outside the clinic, right? as a collaborative, as a network, what are we doing to sort of examine the impact of other things outside of our routine work that will impact people living with diabetes as well? So what are conflicts? And what's the role? What role do we have to play there as a network, as a collaborative? How about climate change? How is that impacting us today in clinic? And what can we think about doing as we start pushing that outside of that? About LGBTQ plus health, and what does that look like? And how's that impacting diabetes outcomes? So really thinking very broadly as a network, as a system, on what's happening in clinic, what's happening outside of clinic. And the important and beautiful thing about having a broader network like this is you start to have multiple people with different interests, being able to like, well, I want to work on this piece, I want to work on that part, and sort of have that shared leadership to drive us and push that piece forward. And we do all of this with ongoing improvement, ongoing quality improvement, and publish extensively. There are over 100 publications in the last 5 years from the T1D Exchange Network on our work around health equity, our work around quality improvements, and sort of show you a snapshot here. Clinical diabetes has been a big partner for us, and we've had many papers with the clinical diabetes. But the work moves beyond just the ongoing routine quality efforts, but also thinking about how do we even start to automate changes locally. And I'll come back to our best practice advisory when I talk about health equity and the work we're doing there. So the last sort of phase of my talk today, it's on all of these old concepts. We can use them to optimize care in clinic today. All of these concepts, we can use them to optimize outcomes and care for even outside of what's happening in clinic, the advocacy space, in the sort of the more social space. What about equity within the system and within our work there? We've worked extensively on this topic and also sort of published extensively on it as well. And just sort of highlight a few examples here. And I will talk on some of this as we sort of wrap up the whole concept of learning health network, and really using that as a framework, as a tool to drive and push equity in practice. So Dr. Adala and Anta did this paper looking at where we are with equity across the collaborative and who is doing what and what resources are available and where do we move from there, and that's one of the sort of first starting points in a lot of our equity journey. It's getting sort of a good overview on where things are and how do we sort of move that piece forward. And two things to really highlight here is you look at resources and the availability of resources to support housing assistance or transportation or food insecurity. One of our main aims with this paper was really to look at the differences between the peds and the adults, but then you can even start to factor that clinic by clinic on the ped side. What does social service support looks like at Stanford versus what does that look like at NYU, and what can we learn from NYU or what can NYU learn from Stanford and vice versa? Really sort of starting to have this conversation on what's the capacity, what's the infrastructure, how is that different? What can I learn from the other side to use that to build and push that work here? And then, we also sort of continued with looking at bias and sort of the role of bias and race-mediated, insurance-mediated bias with this work that Dr. Dalla led with my colleague, Dr. Besson. And our aim here was to use a tool that has been developed here at Stanford to sort of push the conversation on how does race-mediated bias, the DPIP2, and how does insurance-mediated bias play a role. And, Nanta has published extensively on that topic as well. But we sort of use that same tool and, to explore in our network to look at that piece. Now, two quick things to sort of highlight here, and the talk tomorrow for those that will be at the end of grand rounds, I'll spend more time on some of this. But the main thing to sort of highlight here is even the impact of practice years and years of practice on bias and the ability to recognize your own bias and what that means, and sort of that sense of, well, do I have a bias? Don't I have a bias? We all have biases. I have my own biases. I had my bias about coming to Stanford, and I'm sure you all had, all of us have some sort of biases, right? So, but again, there's the conscious one, there's the unconscious one, but more importantly, what do we do with that? What do we do about that? one of the ways we're trying to tackle this is automating our processes. So one project we're working on is a best practice advisory, where we know there are biases in recommending and prescribing technology for people with type 1 diabetes. So now we're working with 8 centers to automate that prescribing and recommending process with the best practice advisory. So if a patient is not on that technology, it pops up, Ms. Smith is not on AID, and the ADA recommends Ms. Smith should be on AID. For you to X out, and if you're not recommending that technology, you need to give a reason for that. And when I was tracking the reason for why Ms. Smith is not on that technology, but more importantly, we're having some sort of a forced conversation on has been recommended, this is what it should be, why is this person not on it, and give a reason for that, and really push that to move that work forward. And there are lots of different tools that can help us do this, and we've published on many quality improvement tools that we can use to bring this work into practice to help us get that field there. And then this is another sort of framework, a 10-step framework we're using, thinking about the problem of sort of equity from a lens, a QI lens, a learning health network, a learning health system lens. Again, my goal with all of this is finding a community of people that are willing to share data, share insights, finding a community of people that are willing to think about what problem are we trying to solve, let's solve it together, and let's make sure that what I'm learning here is being spread and is being shared across. We're bringing that same lens into the equity space and sort of creating different tools to help us do that. And efforts like that can make a difference. We published this piece looking at our work around trying to use the same insight, the same efforts to shrink gaps in access to CGMs. And in this case, we looked at CGM use by race ethnicity. And you can read more in this paper. But what we found is when you have a lot of those sort of concerted strategies, bringing an equity lens, bringing a quality lens, you can start to make an impact in reducing some of this gap. And I'll show you my example. So you look at where we started 2016, 2017 with this work. And again, we still have some gaps there by insurance, but we're shrinking those gaps over time and also working with Medicaid and working with some of the other big stakeholders as well to push that piece. So this is where we started. This was the problem. This was what we're trying to solve with a network, a collaboration, coming together, really trying to change this narrative, change this divide, because we know that in Germany, in Austria, in England and Wales, their outcomes were different. Even in the same time period, when they compared 2010, 2012 to 2016, 2018, they had better outcomes. So we know there's something different. And one of the things they do differently, it's sort of having a community of benchmarking and a community of sharing. So that's working there. And there are also other things working. But we know that, so if we bring in that same lens in the last 5 years, more actively, intentionally, 2017, 2018, 19, all the way now, we've really been laser focused on pushing that piece forward. And this is where we are now. And this is data showing, with more than 80,000 people that was in this data set, that we can change that narrative. We can collectively move from, where things were just 5 years ago to outcomes getting worse, to even though they were getting better outside of the US, to where things is now, where outcomes are improving, and we want that downward shift, looking at A1Cs, which is also what we're seeing too in other parts, in other countries, as opposed to what was happening in 2018, where they were getting better, we were getting worse, but now we're all getting better, like we published in the recent Lancet paper. And you can read more too. We also have a book, that sort of captures a lot of the lessons we've learned in the collaborative 14 chapters, really looking at different aspects of care improvement from the learning health network lens and where we are with that and how we're pushing this piece. And I think we're at the point now where we published this paper just last month on sort of by centers working together, participating in a learning network, a learning health system. We can improve outcomes like I've shared, but more importantly, we can also start to close equity gaps, and you can read more about some of that in that paper, also sort of the comprehensive series and in the book there. So that's the journey so far, and I might get in trouble for sharing this because I thought it would have been out by now, but it's not. But it's still coming. So I hope I don't get in trouble. So, but anyway, I'm already sharing it already. But the ADA Standards of Care 2025 will be out soon. I think it might be this week or next week. But more importantly, I want to highlight a new standard that's coming. So everybody still has to act surprised when it comes out because it's but there's a new standard that will be out when this is released. And the ADA standards is sort of the, American Diabetes Association. That's like the hallmark for, our main evidence sort of space in the diabetes space. And 1.5 now says health systems should adopt a culture of quality improvement, implement benchmarking process, engage interprofessional teams to support sustainable and scalable process change to improve quality of care and health outcomes. And we worked with the ADA team and we worked to also sort of support all of the evidence we've been generating collectively for the past 5 years. And then even outside of our network, other networks, sort of being able to make a statement like this. And you remember where we started from, there's all the research leading to evidence, leading to care improvement. And now we're seeing this now being sort of the standard of this is what it should be. Everyone should be involved in this. So if you're in the diabetes space, this is going to be new where it is the standard of care. We all need to be involved and be sort of in addressing this work and working together to make that change. So we're really happy that that's coming and that's going to be one of the work we'll do collectively to push this across the country. So I've talked about a lot for the last 45 minutes, and you all have been patient, and we'll have time for questions, and we'll have time to talk to sort of have an engagement as well. But my whole goal with this talk is number 5, is to encourage your participation in the Learning Health Network, to help you, to encourage you to think about, are you involved in one? If you're involved in one, can you go deeper in working through that with that? And if you're not involved with one, can you find one that exists? If you can't find one that exists, can you create one? Because we need all that research to lead into practice, and the Learning Health Network, Learning Health Systems are a way to help us get there. So do that, and I hope that we'll sort of be able to push this piece forward and do that for these guys. I appreciate it. Thank you all.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.